Description of disorder. In this video, we are going to discuss otitis externa. It is also known as swimmer's ear, since it usually occurs from prolonged exposure to wetness. This hearing disorder is common among children, adolescents, and adults. Symptoms include atulgia, itching, and inflammation of the outer ear. Patients may or may not experience hearing loss with the disease.
There are many factors which cause AOE. Regular cleaning of the ear canals will remove cerumen, which is a very important step to avoiding moisture and preventing infection. Some earwax is necessary as it creates a slightly acidic pH that prevents infection. However, this can be affected by aggressive cleaning, water exposure, alkaline eardrops, and soapy deposits.
Differential diagnosis. In order to provide appropriate treatment, it is very important not to misdiagnose otitis externa. There are many considerations to be made, and the following are common misdiagnoses. Malignant tumors. If a patient diagnosed with AOE is not responding to the treatment, they should be screened immediately for tumors. Ramsay-Hunt syndrome. This is an infection caused by the varicella zoster virus. Pain and swelling of the external auditory canal can be confused for AOE. However, Ramsay-Hunt syndrome also presents with facial nerve paralysis and sensory neural hearing loss.
Metal sensitivity. Swelling can occur after a certain metal, commonly nickel, is inserted into a piercing. A skin patch test should be administered in order to confirm that it is a mental allergy and not AOE. Lost hearing aid batteries. Hearing aid batteries can dislodge and end up in the external auditory canal, causing swelling and irritation. This can be very dangerous, and so it is important that the condition is identified and the symptoms are not confused for AOE or any other condition. The battery must be removed as soon as possible to avoid complications.
Relevant audiologic assessments. Clinicians should first ensure that the patient suffers from AOE and not from any other cause of atulgia, otorrhea, and inflammation of the external ear. The diagnosis of AOE requires a rapid onset of symptoms with signs of ear canal inflammation. A clinical history should identify any factors that include the patient's exposure to any contaminated water. These can be presented with or without hearing loss or pain to the external ear when chewing. When the clinician is certain that the patient has otitis externa, they should assess the patient for factors that may modify the regular course of treatment. Examples include a non-intact tympanic membrane, a tympanostomy tube, or diabetes.
Diagnostic testing may cost extra, but it is worth it to rule out a differential diagnosis. For example, patients with diabetes require special consideration because they are more susceptible to necrotizing otitis externa. This is a very aggressive infection that mainly affects elderly, diabetics, or patients with an impaired immune system. The disease can invade soft tissue, the middle and inner ear, or the brain. To avoid this, patients may require a different course of antibiotics to manage symptoms of AOE.
Lastly, clinicians should assess patients with AOE for pain complaints and recommend analgesic treatment based on how severe they say the pain is. The benefit of this assessment is to increase patient satisfaction, which allows for a faster return to normal activities. The pain that is caused by AOE can be very intense and severe. Therefore, pain relief is essential. Knowing the dose, timing, routes of delivery, and possible effects of an analgesic is required to control the pain.
Sample audiograms. When an audiometric hearing test is administered, a series of beeps are presented, and the patient will report whether or not they can hear each beep. Patients with otitis externa often cannot hear the beeps, especially in higher frequencies. This is because the swelling of the outer ear canal can affect the patient's conductive hearing. The audiogram will show a conductive hearing loss. However, this is temporary and will subside when the ear becomes less swollen. This is a very common problem when testing with headphones, but it can still be an issue even with inserted headphones.
Audiogram 1 depicts an adult man who has chronic otitis externa in his left ear. He was also experiencing severe itching. An otoscopy could not be performed in the left ear due to inflammation. The otoscopy of his right ear was normal. The audiogram shows normal hearing in the right ear and a conductive hearing loss at the high frequencies of the left ear. Tympanometry in both ears were type AN, and Ipsy reflex was present in both ears. There was a discrepancy between the audiometry and the tympanometry of the left ear, proving that the audiometry result was not a true hearing loss. The acoustic reflex should be absent in conductive hearing loss, but the tympanometry exam proved that it was still present. Audiogram 2 presents an adult patient with chronic otitis externa in the right ear. This patient also complained of severe itching. Similarly to the first case, otoscopy could not be performed in the right ear due to swelling. Otoscopy of the left ear was normal. Tympanometry was type AN bilaterally, and acoustic reflex was present in both ears. Audiometry was performed with headphones and showed normal hearing in the left ear and a sensorineural hearing loss at the high frequencies in the right ear. The test was then redone with insert headphones, and this time there was no hearing loss present. The sensorineural hearing loss was an error caused by the standing wave effect. This is important to ensure that there are no inconsistencies between the hearing tests so that a patient is never misdiagnosed.
Possible treatment and rehabilitation. Current studies show that topical antimicrobials should be the first course of treatment provided for AOE. They improve mild to moderate AOE in 46% of cases. The course of treatment should last 7 to 10 days and can be prescribed with or without topical steroids. There are inconclusive results from trials on topical steroids preparations in terms of lessening pain associated with AOE. In the event that the ear canal is swollen shut, an expandable wick can be used to reduce swelling. This is very common practice used by audiologists, however, there are no trials to prove its effectiveness. Response to the treatment plan should be noticeable within the first 72 hours, and a full response can take up to 6 days in the case of no response. We must further examine the conditions for an alternate diagnosis.